Welcome. It is my great pleasure to spend today with Susannah Fox, a dear friend, dear long-term friend, maybe too long, we don't want to admit that, who has had this amazing journey from studying as a researcher, the relationship between the internet and humans, and then ultimately the internet and medicine, and then to the place where you ended up being the chief technology officer of Health and Human Services, literally the largest agency in the world, trying to figure out how to advance technology in the interest of the people that you have been understanding. And I think now I can comfortably call you an advocate, that you have moved to the place where it's not just information, but it's now time to actually change the system to deliver for the people that you have been working so hard to understand and on behalf of. And so it's an incredible pleasure to be here, Susannah, and thank you for joining us.
Well, thank you. And as you know, I would not have claimed that role of advocate until recently, because as a researcher, you never want to put yourself in the story. You never want to center yourself, and I still don't want to. But we've all been broken open by the pandemic, by our own personal experiences, and it's time to step into our power and speak the truth. And the truth is that, yes, I have become an advocate. I can't help but speak for all of the people in rooms where I get to be invited, and lots of people don't have that privilege.
Well, I think I've shared that with you the whole time, and I think that is what we are here to do. How do we break that wall down and bring, what is known, connect what is known, so that people's lives can be made better through their own actions. So when I was getting ready for this, I went back and I looked at how long you've been doing this and how long we've known each other. And so I wanted to start by asking, like 23 years ago, I believe. And you started this work of measuring what consumers were doing. And tell me about that very first experience, what you learned, how that changed you at the beginning. And I know we're going right to the beginning, but I think that moment where you sort of realize as you looking on the other side of the wall. So tell me about that, please.
Oh, thanks. So when dinosaurs roamed the internet in the year 2000, only about 50% of American adults had access to the internet. It was 5% of homes had broadband. There were no iPhones. Throw your mind back to that era. And the Pew Research Center asked me and my colleagues to start looking at the social impact of the internet on American society. And healthcare was one of the first issues that we looked at. And to situate ourselves, I sort of think of that era as fools rush in where angels fear to tread. I didn't know what I didn't know about healthcare. And so we wrote a national survey that asked people all kinds of questions about whether they were looking online for health information. I really didn't realize that it was going to be groundbreaking. And on a personal note, I hit send. I turned in the final report for that first report that I wrote, the Online Healthcare Revolution. I turned in my final report and gave birth the next day to my first child. So I can really date the birth of my interest in health and technology with the birth of my first child, who's now 23, going to turn 24 in November. And it made a huge splash. I like hilariously, I was on maternity leave and our work got cited in JAMA. And I didn't realize what a big deal that was. And that set me on this path of curiosity and discovery and realizing that the internet was flipping the power structure, flipping the information structure to give people access to information and to each other.
Since my daughter was the same year, and both of our children have now graduated and are now off in the world, and that was around the time I started my work. I completely resonate with that moment, and I use the internet as a researcher to try and assemble a new way of doing research. And it's hard to understand the difference in the world before that and after that time. Like we went from not having access to anything other than when in person or direct communication to having access to everything. And that report, it shocked the world. It changed the way the AMA and everyone regarded and thought about their roles. And I think you chartered how, as people connected to each other, there was a fall down of the sort of curtains and the things that were hidden, and they started to open up, and it was a different time. So let's go forward, because you studied this for a while. And then, suddenly we're with these kids trying to like influence the system. And then suddenly we were not the kids any longer. We were the ones that seemed to have a little bit of, and then you, not just a little bit, ended up coming to this place where you got to determine, after the ACA and the great work that was done by friends of ours that created the modern health systems, and some not so great work, you got to go and be the one that directed this agency to figure out how to use all of its resources to serve its citizens. And tell me about that transition and what that was like and what you learned from that experience.
So I should quickly say I got to run the Office of the Chief Technology Officer. I happily did not get to run the whole agency.
But I don't know, Susannah. We always say technology runs everything now, but I agree. I understand what you're saying, but like it was like, but technology.
I don't want that promotion, to be honest. So the role of the CTO at HHS was, it had two parts. One was the Open Health Data Initiative, and that, my two passions are data and user-driven innovation. And so half the job was helping to run the Open Health Data Initiative, and that is the basic principle is that the US government collects and holds so much data in its health agencies, from public health data at the Centers for Disease Control to all kinds of drug and device data at the FDA, to the discovery data at NIH, all the way through, plus, of course, all the claims data that's held by Centers for Medicare and Medicaid Services. And the Obama administration saw this opportunity to open up these data sets to make them actually accessible to people. Instead of publishing PDFs online, it should be machine readable format, with not only a goal of transparency, but a goal towards entrepreneurship, and the sense that people can create things with data, and it's government by and for the people, and people should have access to the data. This is right in line with everything that you and I are obsessed with. The other part of the job is user-driven innovation. This concept of bringing the spirit of Silicon Valley, the spirit of entrepreneurship, the spirit of innovation into the largest agency in the federal government and all of its operating divisions. We taught federal workers how to think like entrepreneurs. We had a venture fund. We had essentially a startup incubator within the department. And the initiative that I started while I was there was focused on device innovation and making sure that we were listening to people who actually use medical and assistive devices. Because otherwise we're leaving half the team on the bench. If we don't have an intake valve for getting that lived experience into the work that we do, then we're completely missing out. So that was my portfolio as CTO. I'm very happy to say that the technology part was more the spirit of technology. I had nothing to do with making sure that the servers were running. I had nothing to do with everybody's email. And again, that's not a job that I would want, but running the innovation lab and the open data lab was awesome.
So this is what I think is the connection to ICHOM and the same insights that Michael Porter brought forward, and Stefan and Martin, the sort of the founders of ICHOM, which is, Michael had this vision of how do you get things to begin to have information flow and connect and have real ability to have the market be shaped by value. And you measured how that was working, and then were responsible for distributing that in many ways. And I think what was exciting to me about having you come to the conference and connect to everyone and this conversation now. So Rebel Health, which is on the bookshelf behind you, which I think is kind of this bomb in the middle of research and technologies, is coming back and basically saying, yeah, this is all about someone. And I think, for all of our work in outcomes and value and the markets, at the end of the day, it is a human story where all of this gets real. And, and I remember talking to you as you were getting ready to write the book and bringing these ideas together, and then disappeared, to do it. How excited I was going to be. So so take us to the reason we're doing all of this. Like, how does what ICHOM is going to be working, which what ICHOM does, and the ability to measure outcomes, what the data silos that we're breaking down make available, and your understanding of what people use this to do, bring it together.
So I'm super excited about coming to the conference in Amsterdam, because it's going to be a chance for me to meet this international community of change agents within medicine, and clinicians, patients, researchers, survivors, stakeholders who not only believe in change, but are creating change. And this focus on data, which is, as you know, a shared passion of ours, and clearly a shared passion of everyone there, that if we don't measure it, we're not going to find out the truth. And we not only need to measure it, we need to make it open and transparent so that everyone can learn from this in an international community. Something when I talk about the patient-led, survivor-led, caregiver-led revolution, and when I wrote about it in my book, I thought about how many international examples I could bring in, and there are some. I talk about Sarah Rigger, who's this incredible patient in Sweden, who has transformed her own Parkinson's care. And I talk about some other examples, but I focus much of my research has focused on the US. And some people say, is the Rebel Health spirit unique to the United States? And some international friends of mine say, I think it might be because the American healthcare system is so very broken. You have to hack the system. You have to be cowboys and pioneers and build a secondary system for yourselves. But I would say this is an international movement for change, and that it may be in the United States, people are building this out of necessity, but the same spirit of patients wanting a seat at the table in the design of a tool, in the design of a clinical trial, in the design of a practice change, that's international. And that's what I'm excited about talking to people about in Amsterdam and learning from this international community.
I think this is, you're touching on one of the great insights that I think brought ICHOM into existence, which is the idea that how we care for Parkinson's patients in Sweden and how we care for Parkinson's patients in the United States or Brazil or Japan, there are lessons to be learned in the variations and how that occurs. And Sarah, who I also know, and her quest for the information to compare herself to people, to learn what others were doing and how to do it, that I don't think is uniquely American, but I do think what might be somewhat uniquely American. And this is sort of the George Bernard Shaw quote: "All progress depends on an unreasonable person." And I think that you can't but be unreasonable in the American healthcare system today. Like if you want to get something of value out of it, you have to be unreasonable. And that unreasonableness may have lessons that can come back to the systems that are a little more caring, or a little more gentle, or a little more paternalistic, that people are dealing with. And I think, Sarah chafed against those constraints where she was, and transformed her own life through it. So one of the things that and I love being on the board of ICHOM. I love watching the standard sets evolve, and the fact that patients are involved in all of the steps. I was very deeply involved in the autism standard set, and listening to how the advocates were connecting and the patients as part of that. But I think we don't spend enough time doing what I think you did in Rebel Health, which is sort of really pay attention to what data, what insights are needed, what would change that. So like if you were bringing the whole thing back and said, like, you could change this about how we convey health information, or how we collected health information, because I think that's what ICHOM's trying to do, is build the next generation of what's going to let people have agency. What would you bring back from all of those stories and guidance to say, let's give them this better, more effectively?
One of the overarching lessons that I have learned from spending time in patient communities of all kinds is that people's needs are not being met in a diversity of ways. And often those challenges are invisible to mainstream healthcare. And having some humility around what we know and what we think we know about the problems and challenges that are being experienced by patients and caregivers is key. So there's a lot of discussion these days about patient engagement and patient focus. But if we change our language to patient-led, which is what I'm calling for in the book, we would see that we would really start to remove blinders in new ways and start to see the full landscape of suffering, and therefore the full landscape of opportunity for change. And I think about, for example, to touch on a really tough subject is people who are vaccine hesitant. I look at them, I try to look at them, at these folks with empathy, and say, these are people whose questions are not being answered to their satisfaction.
Mm-hmm.
Their needs are not being met. Mm-hmm. And for the most part, they are riding under the radar of mainstream healthcare. How might we meet them where they are? How might practices shift to answer their questions and meet their needs? I also think about, I know that standards of care for diabetes is a big focus. And when you think about what it's like to be the parent of a child with insulin requiring type 1 diabetes, it looks to many people, to an outsider, it looks like a solved problem, because there are medications. If you're lucky enough, you have a continuous glucose monitor. But of course, the usual way of business, the old model, is that the device companies, and frankly, the drug companies, see their customer as the prescribing clinician. They don't see their customer as the patient or the caregiver who's actually using the device. And about 10 years ago, patients in the United States broke that open. They literally were able to jailbreak a continuous glucose monitor, get access to the data, and that created a cascade that 10 years later, it's now standard practice for devices to have a share function for the data, because of course, the data generated by our own bodies is ours, and we should have access to it. But guess what? Diabetes devices stand alone. That revolution has not yet come to cardiac devices.
Right.
There's no other devices that have made that shift. Why not? I'm going to call on clinicians, researchers, executives all over the world to start thinking of themselves as serving patients and not the prescribing clinicians.
Taking apart a couple of the things you said, and I really want to agree with and sort of double down on your first point. When I started Patients Like Me, my idea was, here I was, this expert at this institute that studied ALS, and I knew all these ALS patients, and I was going to share my knowledge with them to help them. And it took about like 2 days before
we all know where this is going.
I know it took 2 days, and I was like, I didn't know that. And like suddenly it was like, to me, having been in that intersection, I thought I was in their homes understanding it, but I think the breadth of what I didn't know just overwhelmed me. It was and that became and the second point you made about lead, there's 2 parts to this that I think we misunderstand, which is the healthcare system takes away your agency in general. It's like, let the doctor decide or let the system decide. And there are these points where the patient should have input. Input what? Into their lives? Like the sort of the absurdity of that comes down. I mean, and to me, when you say patient-led, when we studied things with patients, I often found that they were right. You mentioned the vaccine thing, which I think is more complicated, but the questions they're asking are the ones that need to be answered. The fact that they weren't answered, and the data isn't even available in the form that would help people understand, means that the science isn't there. Because in the end of the day, the person that should be deciding what to do is the individual, right? So that humility is so essential. I agree with you. Let's go forward a little bit to Michael's vision being realized. And Jennifer and the team at ICHOM have driven forward and created and delivered these scaled measurements in the world. What do you think that you do with individuals, and how would that change the dynamic of the people with access to that data and using it, and the healthcare system? What do you see? And maybe even because what do we fantasize about what's possible here, assuming we unlock outcomes that matter?
Well, if we're spinning forward into the possibilities of what good can come from this, I would say that we would be able to have a growing an evidence base that shows the promise. And what we have to acknowledge is that this is always going to happen in pockets. It's going to happen in fits and starts. And to show that these outcomes measurements can really help patients in certain conditions, in certain places, to have that spread. And this is actually where patients and survivors and caregivers can help us. The most visible part of the patient-led revolution are this group that I call the networkers, who, when they see something that works, they are able to spread it to everyone who needs to know about it. And so this idea that clinicians and researchers and patient advocates can come up with this beautiful thing that they launch into the world, and that's going to be enough, is false. We need everyone to help. We need everyone to not only know about it, but share it and advocate for it in their own condition or disease, or in their own region of the world. And that is one promise of the patient-led revolution, that up until now, we have been leaving half the team on the bench. We have not harnessed the power of patient communities. And so therefore, we are only getting part of the way there in terms of dissemination and adoption of the measurements.
This thing that you just said about the patients being the networkers, the bringing of the data, the sharing of the insights. Again, I think this is something that is kind of a false flag that medicine uses to defend itself, because they say, well, patients can't make their own decisions, and to some degree they're talking about the average consumer, and they're saying the average consumer doesn't understand this, or the average consumer doesn't understand that. And you know what? They may even be right. But I think that what you're talking about and have shown, we certainly saw this at Patients Like Me, and I think is broadly what's going to create change, is it doesn't take that many people to really come in and say, I have a different view on this data, I have a different view on this insight. And then that goes out, and if 1% of the people that a doctor sees teaches them something new, we just changed all the medicine more efficiently than everything else, right? So so I think that the team on the bench is the shared insight of people not blinded by their prior biases, with the right understanding of the problem as you articulated, bringing that forward. And I think that's the hope, and the false flag that, like, it's not about just giving everyone total freedom, though that might be okay. It's really about having the best minds, including the people with the problem, come after the problem.
And you're pointing out something that's really important to note, and that is there are people who want the old way of doing things. They're exhausted, they're stunned, they don't understand the science, and they want to be told what to do. There absolutely is a group of people, that's how they react to illness, that's how they react to a new diagnosis. When I started looking back at the 20 years of fieldwork notes that I had, I looked for patterns in how people react to a setback, how people react to a crisis. And that's when I saw these patterns that eventually became the 4 archetypes, where there are some people who, when they're experiencing a mystery, or their child has mystery symptoms, there are some people who realize they're not getting answers to their questions, and they go out on the hunt and they don't give up.
Yeah.
And there are other people who are networkers, who pool resources. There are other people who are solvers. Jamie, you are totally a solver. Engineers are natural solvers, people who look at something that's not working and they can't wait to take it apart and put it back together again, whether it's a system or a device. And then champions. Champions are the ones who are shining a spotlight on patient-led groups and giving them the regulatory guidance, the funding, the platform to bring their changes to the fore. And I would say, and I love your reaction to this, I think ICHOM is a champion. I think that they are champions for patients contributing to the work that they do. But what I'm going to call for is that they step into their power even more and start creating more ways for patients to gather peer-to-peer, and allow patients to lead some of the work that they're doing.
So I love that. I love that challenge, which I think is why you're here, and that's why we want you here. And I'm very excited about all of this being part of the conversation in Amsterdam, and sort of celebrating that. Let's go into that lean forward, because I think this is it takes a lot to get your and my attention to some degree, right? Because we have real passion for how we're going to change things. And what I love about what you said, and I just want to echo, and then I'm going to ask you at the end to just sort of give us the sort of teaser, like what's the actual challenge you're going to lay down, so people got to come hear it, because it's magical to hear you talk in person. But the thing that I really want to lay down as a challenge is I'm here at ICHOM because I know that there are essentially only two levers that can change how something works. And that is when the people in it have the power and the agency to force it to respond to their needs, which I think is what Rebel Health is about and what you have been trying to drive into the system and illuminate and illustrate. And the second thing is the data that gives them the tools to fix it when it's not. And and there are other ideas in the world, so I don't want to say it, but like there is no other lever I know of quite as powerful for bringing into alignment this system that doesn't check whether the things it did helped people. And I think that's the other part of the story. Like all these friends we have that have gone through tragedies or issues, or the system doesn't track it. And so the idea that we can have outcomes that are measured, that matter, and we could know what works and learn it, we could distribute it to the people that are going to force that change, which I think as much as our audience as physicians and people that want to change, the forcing comes from the consumer. The forcing comes from the person in need. So anyway, I'm so aligned with you on that. I'm so excited to sort of have you here to lay that down. So give me give me the challenge. What are you going to lay down for us?
Well, I'm going to talk about how it's unique in the world to some degree to bring together this group of people. And, but there are continue to be missing voices. And I want people to step into their power as champions. I want people to open more doors to the patient advocates who, by the way, are in your practice. You just haven't asked them yet. I am super excited that Sneha Dave is also going to be a speaker because she is an example of exactly what I write about and talk about. And that is someone who walked through fire, lived to tell, and is going back into the burning building to save as many people as she can. There are so many ways that ICHOM can learn from patients. And the message that I also want to bring is that innovation is incredibly hard. People who are coming to this conference probably pretty often feel alone at their institutions. They might feel alone within their discipline. And that's actually how patients feel and caregivers feel when they are experiencing a new diagnosis. And the promise of the revolution, the promise of peer-to-peer healthcare is that you are not alone. There are people who would love to help you if only they knew how to find you. And ICHOM is that opportunity to come together with other rebels, with other people who believe that change is possible. And so take every opportunity to learn from each other while you're there. And I am going to give you some tools and strategies to think about for what to do when you leave and when you go home, how to engage the rebel leaders in your communities.
That is exactly the challenge that we wanted you to bring. And I am so looking forward to spending time with you there and connecting to all of the fellow rebels that are going to help us bring forward that world that we both want. So thank you so much, Susannah. It's been such a pleasure to talk to you today. And I look forward to seeing you shortly.
Yeah, see you in Amsterdam.
Great.